to have these people with us. I called Dr. Vinay Gupta, Dr. Vishal Agarwal, Dr. Amit Verma, Dr. Shom Malhotra, Dr. Amit Jaiswal. I think these are the 5 core committees which we have made, and they have worked wonderfully day in and day out to make this program to come to this stage. Now, what we decided by cannot be explained in English. I think I need to say one couplet around it. What we and Dr. Prasad have decided, होकर मायूस न शाम की तरह ढला कीजिए, होकर मायूस न शाम की तरह ढला कीजिए, जिंदगी एक भोर है, सुबह की तरह होगा कीजिए, सूरज की तरह होगा कीजिए। एक पैर पे खड़े होगे तो थक जाओगे। आई एम टॉकिंग ऑफ द टीम। एक पैर पे खड़े होगे तो थक जाओगे। धीरे धीरे ही सही अपने हिदायत की ओर चल रही, हिदायत इस टारगेट, धीरे धीरे ही सही अपने हिदायत की ओर चल रही है। That's why I think we have taken this shape. Now I call upon Dr. S. Prasad to say a few words in the outline of the course. I think he was the first person when we were sitting together in 2003 and 4 before taking into course. We conceptualized this idea, and we were thinking at that time was arthroplasty was at the fetal stage in Kanpur, not even in infancy. And that time we have decided this course. For him, I think he doesn't need any introduction. इनके लिए कहना तो हिमालय का आइसक्रीम दिखाना है। The other thing is that तू सूरज से, what can I say for him? तू सूरज से उजाले की खैरात ना मांग, तू जुगनू ही सही, अपने रोशनी पे तो एतबार कर। And that was the basic message for this lecture. A great round of applause for my team.
Thank you, Anand, and welcome, friends, again. Every time I start the program, I get a little nostalgic. And Anand has already said a lot of things, but still, nostalgia, you always takes over. So when I started the program, the idea was to train young people because I had so much of tough time when I wanted to learn orthoplasty. When I passed, I was very clear I will do orthoplasty. In 1988, I said I have to learn it, and it was so difficult. There were so few doctors, and who were there, they're not willing to take a disciple or student who was from Kanpur. I went to Mumbai, I went to Delhi, I went to Chandigarh. These are the 3 places I could think of. The person who was agreeing was Mohandas. Mohandas said, yes, you come on, but I went to Chennai, I was a little scared, and it was not easy to go. Anyway, I started doing with the help of some seniors. I was only shown the surgery in Delhi, first time the hip, and knee I could not unless until I went abroad. So anyway, friends, the first time we started the training program, the idea was conceptualized by one of the DP person. When I was always scribbling, this is bad. The people of, the surgeons of my area do not get training in arthroplasty. So Shushoban Das Gupta of JPU, he agreed. He said, Dr. Prasad, if you are really willing to, we are going to help you. And that's why in 2005, the first one-day hip course started, not the knee one. And we showed a resurfacing technique and a total hip. So that was the 2 surgeries. So our focus was initially to show live surgeries and talk about basic things, indications, exposures, and whatnot. Absolutely basic. After a couple of years, we formed a committee to do it in a streamlined way, not only industry-based, and we started taking help of other players in the field of orthoplasty. And the basic core committee was formed, was absolutely of my friend, because we wanted to do a work where we could work. So I think Dr. Rajesh Jain, he is there. Rajesh Uparajo. Rajesh Jain was the chief of my team, surgical team. He is the anesthetist. And 1 year junior to me, but we worked as a team. Dr. Loken Singh, where you are? Loken kahan hai? Dr. Loken Singh was 1 year junior orthopedic surgeon. He was my house in my college and big entrepreneur. He owns a big hospital, so इनका दिमाग पैसे कमाने में ज़्यादा है. तो ये दो मेरे पिलर थे and Anand was my intern. So Anand Nigam, please again you can come. So you can understand how I started building a team. Dr. Vinay Gupta was working with me, Dr. Vishal Agrawal, they were working with me. So ये तो ऐसे ही operation जब दिखाते थे तो they were always there. Dr. Vishal, Dr. Vinay, please आ जाओ. Vinay Gupta कहाँ है?
Now they are the top peers now.
So this was the basic
Hello.
team which started the arthroplasty course. And now we have taken a conscious decision to. In fact, I was discussing with all my colleagues, we have to fade out from the active part of this. And in last couple of years, Dr. Vishal and Dr. Vinay were doing all the work, and I was always needling them, they do this, do this. So from this year on, you will be surprised to know the whole agenda. I told them the concept because the agenda, the quality of agenda or the topics we are discussed, that it should be case-based. It was decided in the last meeting. We had a talk with Dr. Anil Oman, who was very clear that it should be only case-based. And we have taken that advice very seriously, and we have tried to do this course as Dr. Anil Oman said. And definitely Dr. Rakesh Rajput was there in that meeting. Unfortunately, he is not coming. So from this year on, it is all case-based. And from this year on, the duo of Dr. Vinay Gupta and Dr. Vishal Agrawal, they have taken over. They are formatting everything. And they have taken our friends from all over, who are good friends with them. The two people who are very important for this meeting this year, along with Dr. Vinay Gupta and Dr. Vishal Agrawal, or Dr. Amit Jaiswal and Dr. Shubh Mehrotra. Both are very close to me. Shubh is very close to us. Shubh, please, aap bhi aa jao fir se. I'm sorry, I'm calling you again. But because this is the faces which will be instrumental in taking the legacy of Kanpur orthoplasty forward. Amit, can you come please again?
Shubh was my house surgeon, and for 1.5 years, 2 years, he served me like anything, making a tea for me at 5:30 in the morning. And so, boss, आप पढ़ लो, मैं dressing कर देता हूँ.
So you
I
see,
owe to him and I'm indebted
so
to
you
him.
see, it's all close-knit who are taking it forward. So to take it forward, because it is Kanpur course, so we have got very good people from Kanpur now who are doing joints. Dr. Chandan Kumar is there, Dr. Manav Luthra is there, Dr. Ravi Garg is there. Are they here yet or no? Are okay. So these are the three people who will be in the core committee from Kanpur. And then we have got people from Gorakhpur. Dr. Bharti is there. We have people from Lucknow. Shubh is there. Then Saurabh Shukla will be joining. Then we have got people from Agra. Next generation. All are 15 years junior to me. So they have taken the mantle over. So from this year onward, whatever you will see, you'll enjoy. It is the hard work of these young group who are 15 years junior to me. So welcome to the Kanpur orthoplasty course again. Just wanted to make this important announcement कि तब भी गलती जो है उसके लिए हम और आनंद निगम ही responsible रहेंगे by the way for all the faults which are there. But we are there now watching them how this course will unfold every year. And I'm very thankful to the esteemed faculty who could come here.
Amit Verma.
They're all stalwarts. It really takes an effort to get time and the passion to teach young ones. It's not joke. You have to travel, you have to make preparation, and making a presentation is not easy thing which a delegate might think. It's very tough because you have got too much of knowledge. You want to concise that knowledge into 6 minutes, which should get a take-home message. That's not an easy job, my friend. So I think with this, the baton is passed. Anyone of the young generation want to say anything? They are welcome. And thank you for being with us.
But whatever the future lacuna will be, myself and Dr. Prasad will be responsible for it. That is the most important part.
Sure. You want to say something? Anything?
There is one very good thing in the Wings of Fire by Abdul Kalam, sir. What he said, that at the time, 1 minute, at one point of time, when there was a Prithvi missile was launched, everything was going okay. Then at that time, Kalam said, okay, but the computer failed at the 11th hour. Then the computer said, go and outrule that. And he pushed the mechanical button. It went upside and fell down in the sea. That failed. Dr. Dhawan was the chief at that time. Then Kalam said, sir, this has happened. Dhawan said, don't face the reporters, I am coming. He came there, faced and said, okay. And while going outside, he said, Kalam, what is the next date for launching? Next time when it was launched successfully. Then again he rang Dr. Dhawan. Then Dr. Dhawan said, now you are capable enough to face the reporters, face it. And that's why we are here. That's what we invite from him.
So I welcome you all. So let's start our day. And we start with the first session now, right?
So to start the first session, may I call Dr. S. Prasad sir and Dr. S.S. Jha sir to chair the session. डॉक्टर शुभ आप मॉडरेटर हैं.
Can we have the presentation? Good morning, everyone. Thank you, Prasad sir, and the entire organizing team for inviting me here. Okay, on that one. Can we have the presentation? Yeah. So my topic today is cocktail infiltration for pain management in TKR, and I know most of you must be doing it. And those who are not doing it or are kind of apprehensive about it, I think you must adopt it in your practice. So without taking much time, why we need to do this? Ye ban nahi raha hai. Okay. Why infiltration? Because surgeon knows what's best for the patient. We as surgeons, after the surgery, we understand best how much that pain is bothersome, how it affects outcome. Better pain control basically means very good outcomes. Lesser cost, shorter stay, happier patient. And even before the surgery, the patient is most apprehensive about the pain. So pain is something for which the patient is getting the surgery done, and he should absolutely be comfortable regarding this aspect. So what I do is, my cocktail is simple. I use ropivacaine 20 ml, 0.5, 100 ml of normal saline, 1 ampule of adrenaline, 2 16-gauge Venflons. These are important. Venflons are long needles and straight and stiff. That's why I use them. 2 vials of 2 vials of 80 milligrams of dipomedrol, Anavin 0.5%, and 250 ml syringes. So I am very particular about loading this cocktail myself. I do not believe in my staff. A, B, I am not very comfortable by using pre-sterilized ETO packs because I think the ETO might interfere with the drugs. So just take an ml of Adrenaline, put it in 100 ml of NS, and get about 35 ml of that solution. So you've got about 1/3 ampule of the Adrenaline. To that, we add the dipomedrol, 1 vial of dipomedrol. If I'm doing a dual block, if I'm just infiltrating the knee, it's 160 milligrams of dipomedrol and 20 ml of 0.5 cc of ropivacaine. There are other options like clonidine, dextromethine, ketorolac. I've tried them out. But without those also, this ropivacaine with dipomedrol with an ADR is excellent. So the important thing is we need to use a stiff, long needle. That's why a 16-gauge needle. It's a fresh needle. And it's very important that we infiltrate small blebs, 1 to 2 cc's, not a large bleb, small 1 to 2 cc's. And we start from cover the entire region, right from the capsule. Don't be scared about the posteromedial capsule, the meniscal scar, the entire MCL, the medial epicondyle from where the MCL originates, the entire synovium. All that has been cut, all that is inflamed is to be infiltrated. The anterior synovium, the lateral synovium, go down to the lateral gutter. And since you've got a stiff and a straight needle, you can direct it whichever way you want. And you see, just tiny blebs are going. Even after so many pricks, I've only finished about 15 to 20 cc. The cut surface, the capsule, the undersurface of the quad tendon, that has been done. The lateral corner, which is very important, need to be careful because the peroneal nerve is there. The lateral gutter, the origin of the LCL, the ITB, and if you release the lateral side of the capsule and the gutter, then do that because that's there. The lateral meniscal scar, that's also very important. All things that has been cauterized or cut are very, very important. The medial collateral ligament, the entire pes area. Don't forget the fat pad below the patella. That is also a very important structure which has to be infiltrated. And if you're doing those small blebs, 50 cc in our small knees is good enough. For the medial and the posteromedial part, I like to flex the knee and infiltrate the entire MCL. With this, we are far away from the vessels and go back to the semimembranous structures, the capsules, and the origin of the entire MCL, all the places which has been infiltrated. You can go posteriorly like this. That way you are far away from the vessels and you should not be scared about the vessels. Once this has been done, you are still left with a lot of volume. Now we can go deeper down. By going deeper down, we are going more posteriorly, the entire posteromedial surface, the pes area, the medial area, which is the most painful, which has been all erased from the tibia. These areas are very important for infiltration. So that's how the basic knee infiltration is done. This is done before the implant is put. This is done with the tourniquet on. So with this, this is followed by the cementing and followed by the implantation. What other thing I've also started doing is the adductor canal block. So a lot of you have got anesthetists who can do a USG guided adductor canal block. So USG guided is needed because proximally in the very high and low positions, you see the saphenous nerve is very close to the artery and the vein. But as you go down to the area which is about 8 to 16 centimeters, that is the direct ACB or the adductor canal block area, here the vessels have already gone posteriorly and the saphenous nerve is medially. So this is the place where a surgeon-administered direct adductor canal block can be given. So the second dipomedrol with the Anavin and the saline comes here. So a lot of studies have been done. These have come after 2020, and there's a huge amount of literature from India itself, from Bombay, from 2022, where you would see that the trajectory is, it starts 8 centimeters proximal to the joint line. It is 5 to 10 degrees going medially in the coronal plane and around 20 degrees going posteriorly. And that's how it is done. This is done after the implantation. So you take a point 8 centimeters proximal to the knee joint line, or that is basically 2 finger breadths above the top of your knee. And from here, your second syringe comes, go inside. Again, I prefer using...
You have to conclude.
We prefer using a stiff needle because the spinal needle can wave off, and then we take the direction about 10 degrees medially and about 20 degrees going posteriorly, and aspirate it well so that the tourniquet is off. So aspirate it well, you are sure that it's not in the artery and the vein. And as you infiltrate, you start pulling out the needle. That's how it goes. So finally, to conclude, periarticular infiltration plus a surgeon-administered direct adductor canal block is a very good pain intervention. It really takes care of the pain. And just Google surgeon-administered direct adductor canal block. You will get a lot of articles. These are full articles, free, and you can just go through them, and it's an excellent way. Thank you.
Thank you. Thank you very much. Now we call upon the next speaker, Dr. J.K. Laik, for his presentation on factors affecting and overcoming difficulties in total knee replacement surgery. We will be having discussion at the end of this session.
Good morning, Darvast Gadri. So many famous surgeons. Basically, my talk is for those people who are starting the career on arthroplasty because what I felt was to be needed on day one. I want to give that. So the question is, whenever you are doing one arthroplasty, it is not about the arthroplasty, but it is about the patient itself. So you have to be very careful about the pre-operative, intraoperative and post-operative problems that are associated. Now pre-operative problems which comes are age group. Be careful if you are doing it below 50 or more than 80. The smoking needs to be ceased 4 weeks before. Diabetes, be very careful. If HbA1c level is more than 7.7, control it. If there is obesity, there is a very high rate of repeat admission. However, there is no such literature which was found out that liposuction before or controlling the weight is going to help you at all. If there is a peripheral vascular disease, be careful about using the tourniquet and also get some amount of referral to the vascular surgeon. Now, intraoperatively, the difficulties which I faced was about the short stature people where the tourniquet may be an issue. In that condition, either you don't use tourniquet or if you are at all using tourniquet, then use adhesive tape to secure the position. And what happens that the table is long, so put the patient just towards your end foot end. There are other issues which comes and difficulty in dislocating the knee, which is very common in the first doers. Now please understand that dislocating a knee is difficult because there is an inadequate exposure. Probably the meniscus has not been cut fully, or probably we have not taken out the adequate amount of the cruciates, or maybe there are certain bone blocks, osteophytes which are preventing the dislocation. Now you can see here that it's not moving. I don't know. No, it's okay. So you can see now the third difficulty which comes, how much tibial defect I should cut. Normally you should cut 6 mm, not 8 mm, because almost every time the first cutters when you do, you normally press it and it becomes 8 mm when you are cutting the tibial defect. So large tibial defects which are very large, that actually don't show so demonic. If you can see this, the defect was looking large, but it was not actually so. Okay. However, you can face sometimes the defects are too big. At that time, either bone block or put some additional ways at your armamentarium. So the first doers should know all these things before proceeding to any surgery. Rather, in the first timers, I will say, don't try to do, the big defect areas. Now, sometimes you can have a void of this nature. What to do about those things? In that condition, you can go for the extension with ways, tibial extension with the ways. The third and fourth problems, while you are putting the entry point to the femoral cord, either you are too anterior, then you can hit the anterior cortex. If you go for too posterior, you might blow the posterior part. Now, you can do it carefully by deciding 1 centimeter away from the posterior cruciate ligament. There are other problems which happens is about the gap balancing. I always put this chart and tell my students to learn it. If the flexion is tight and there is an extension in tight, the first thing you have to cut the tibia. However, if there is a normal flexion and tight extension, cut more distal condyle and release the posterior capsule. If the loose flexion is there, however it is tight in extension, then cut more medial condyle, release posterior capsule and thicker volume. If the flexion is tight but the normal extension, then you have to cut the more posterior condyle. However, if the gap balancing is perfect when the normal flexion and extension, which is ideal condition. If the flexion is loose but extension is normal, then you have to cut the more distal condyle, release the posterior capsule, and use the thicker poly. If it is tight flexion with a loose extension, then also the same thing you have to do. If there is a normal flexion and loose extension, then the same process you can do it permutation and combination. If there is a loose flexion and loose extension, here you have to use thicker poly. Normally the poly is 8 mm, maximum we use 8 to 10, but if necessary you can go up to 12, 15. Now, despite everything, you can cut the notch, which is possible even in case of very experienced surgeon. Normally I will say, please do not use thicker and broad saw, because normally they cut the cortex because of your pressure. Of course, nowadays robotics have come that will prevent all these things. Third, what is more important for us is about the vascular injuries. Most of the cases, unless and until there is a deformity, vascular injuries are unlikely to happen because they are almost 3 cm away from the posterior part of the femoral condyle and tibial condyle. You should always have intraoperatively backup of tibial component, femoral component, avulsion fracture of the tibial tubercle. So you should have a fracture fixation set ready for you. And while doing cementing, be very careful because it takes normally 12 to 15 minutes at room temperature. So keep the room temperature at as low as 16 and 18 minutes. Thank you. I think the basic of these, if taken care of by the new surgeons, will be of help to us.
Thank you, Dr. Laik, for your step-by-step maneuvers to prevent any difficulties that can be encountered.